because we cannot implement this program without a customized protocol in the country, because what the protocol we had is generic, and it was covering research questions and research methodologies for the whole continent. So it was meant to be customized as per the ethical regulations and the existing literature in the different member states. So we have Zimbabwe, Malawi, and Rwanda, Cote d'Ivoire, Ethiopia, Uganda. Those ones have so far completed customizing their protocol, and so far 3, that is Zimbabwe, Malawi, Uganda, have submitted their protocols for ethical approval in their countries. That means the next step is starting off enrollment of their research participants, data collection, and then we shall be able to get the analysis, the results, and then we shall be able to inform the African population of the research questions as per the protocol. And these are the few lessons that we have learned so far as we're implementing and kickstarting the program. We have learned that the lead investigators, over 58% were male, but there's no significant difference, although functional non-national public health institutes were 67% of all the countries and member states that we have so far carried out microplanning. And this is a very important aspect, because national public health institutes are pivotal when we want to roll out national health programs in African Union member states, because they are the entry points to most of these programs in all member states. Therefore, for countries who had existing national public health institutes, it was very easy for us to carry on microplanning, to customize, and also they have been fast enough to identify their principal investigators, and we have been able to submit as quickly for ethical approvals. And majority of the member states, the implementing partners had experience in REDCap management, which is our data management platform software for real-time data collection management and then later analysis. So this means that most member states have experience in data management, and we shall be able to data and analyze our data effectively as soon as we complete data collection in most member states. The changing priorities are, as of the moment, with the COVID-19 pandemic waves, they were non-existent. Therefore, it was hard for us to carry on our research objectives using a prospective methodology. So we had to choose majorly one of the other methodology, which is retrospective. Although the protocol, once it is approved, we can always implement this prospective methodology as soon as the COVID wave is back, depending on the member states' current statistics of the COVID pandemic. It is important to have diversity in research infrastructure in the member states. That is the institutional review boards existing in the member states, data management capacity in member states, and research regulatory frameworks in member states. They should be existent enough so that we can be able to implement this research effectively in the member states. Protocol customization and IRB approvals, they vary in all member states because each member state has their different ethical guidelines, and therefore which have to be followed so as to be able to start off actual research implementation activities. And we have data specimen sharing is critical for a successful implementation, and this is our plan so that we shall be able to share data that we shall have accrued from this research and approve. We shall be able to share it with all member states through their national public health institutes, ministries of health, so that they can be able to learn from any other missing opportunities as per the results of this research implementation. The next coming year, these are our priorities. As soon as we receive ethical approvals from majority of the member states whose customization has completed, we shall start off their enrollment of participants and the research implementation. And that means we shall carry on site initiation visits, including study and research monitoring, to be able to start off research data collection. Also, we have a budgetary addition. We would like to implement a strategy of creating biorepositories in national reference laboratories who are either existing or which can be created, to be able to carry out research and to be able to carry out sample storage for COVID-19 samples for future research and bioinformatics, to be able to have a research data in the future to inform us of the current and the future pandemic on COVID-19. Thank you so much. I would like to stop here, and I'll hand over back to you, Dr. Elizabeth, to take on the next section. Thank you.
So thank you very much, Dr. Leah. So we are looking forward to receiving the real data as we conduct implementation science in 15 member states. So the exciting thing with this is that they are also working very closely with the lab division. They've talked about the biorepository. So some of the SLO funding is also going to support and strengthen that. So we are really excited, especially that we are going to get real data in terms of the implementation science as we are rolling out this new vaccine. So at this point, I would like to transition to Dr. Nyirenda to take us through briefly what they have been doing in terms of safety surveillance. This is something that is also multi-country. Yes, we are building on the existing systems, but the SLL program critically is going to strengthen what is currently happening in member states. So over to you, Dr. Nyirenda.
Thank you very much, Dr. Elizabeth. I don't have a presentation, but I've structured my content as we were guided. So once again, I'm Nyirenda James, and I'm coming from Across Research. For those of you that are wondering what Across Research is a non-governmental organization based in Lusaka, Zambia. Over the past 12 years, we've done work in water and sanitation, malaria, neglected tropical diseases, as well as health systems strengthening. So coming to SLL, Across Research is the implementing partner responsible for the safety surveillance, and we are supporting countries in Eastern and Southern Africa. We have a total of 11 countries. 8 of these countries are in East Africa, and these are Ethiopia, Djibouti, Tanzania, Uganda, Somalia, Sudan, South Sudan, and Kenya. And then in South Africa, there is Zambia, Mozambique, and Namibia. So coming to the scope of our work,